Insomnia is defined as a subjective report of difficulty with sleep initiation, duration, consolidation, or quality that occurs despite adequate opportunity for sleep, and that results in some form of daytime impairment. Insomnia symptoms occur quite commonly in the general population. Risk factors for insomnia include increasing age, female sex, comorbid disorders such as medical, psychiatric, substance use, and shift work. Patients with psychiatric and chronic pain disorders have relatively high rates of insomnia. Causes could be behavioral, spending more time in bed in an effort to catch up on sleep, stress, learned habits which do not enhance sleep, cognitive distortions. For example, if one does not sleep throughout the night, one has not slept at all. So in such a case, it could lead to insomnia. And medicines, for example, for treatment of common cold, hypertension, asthma, caffeine containing beverages like tea and coffee, withdrawal from alcohol and other drugs of abuse like cocaine, marijuana, and amphetamines, medical conditions like sleep apnea, airway obstruction, liver disease, renal disease, and thyroid disorders. Also, psychological and environmental factors. Other psychiatric disorders, such as anxiety and mood disorders, could also cause insomnia. Also, travel, especially across the time zones, leading to jet lag and shift work too. Main symptoms are prolonged average time for falling asleep, longer than 30 minutes, total sleep hours less than 6.5 hours, difficulty falling asleep, frequent awakenings, difficulty returning to sleep, awakening too early in the morning, sleep that does not feel restful, refreshing, or restorative, anticipating poor sleep hours before bedtime, and becoming more alert and anxious as bedtime approaches. Daytime effects of poor sleep: fatigue and sleepiness, mood disturbances and cognitive difficulties, poor quality of life worsened by interpersonal difficulties or avoidance of day activities, exacerbation of comorbid conditions such as depression, high blood pressure, day-to-day variability. Okay, so history taking an assessment of patients with insomnia. Characterization of the sleeping environment: the culture of bed, light or dark, quiet or noisy, room temperature, alone or bed partner, TV on or off. Also, patient's state of mind: is sleepy or wide awake, relaxed versus anxious. Also, identify perpetuating negative behaviors and cognitive processes. Assess sleep-wake schedule with sleep diary and time to fall asleep, sleep latency, number of awakenings, wake time after sleep onset, and sleep duration. Assess breathing, so breathing related sleep disorders, snoring, gasping, coughing, sleep related movement disorders, kicking, restlessness, parasomnias as behaviors or vocalization, comorbid medical or neurological disorders, reflux, palpitations, seizures, headaches. Other physical sensations and emotions associated with wakefulness such as pain, restlessness, anxiety, frustration, sadness. And assess daytime activities and daytime function, like napping, frequency or day times, voluntary or involuntary, and work work times, work type, such as driving or with dangerous consequences, disabled, caretaker responsibilities. So lifestyle, sedentary or active, homebound, light exposure, exercise, also travel, especially across the time zones, a quality of life, and exacerbation of comorbid disorders. Investigations: FBC, BE, creatinine, LFTs, blood glucose, thyroid function tests. Main treatment objectives are reduction of waking symptoms, improvement of daytime function, reduction of distress, and treatment of comorbid conditions. Non-pharmacological treatment: stimulation or stimulus control therapy. Avoid stimulating sleep environments, such as leaving lights, TV, and radio on. Relaxation training, cognitive behavior therapy, avoidance of daytime sleep, avoidance of excessive stimulant consumption pre-bedtime, for example, tea, coffee, alcohol. Pharmacological treatments: first line treatments, you give lorazepam oral in adults 1 to 4 milligrams at bedtime. Children is not recommended. Or you give triazolam oral in adults, in the elderly, 125 to 250 micrograms at bedtime. Less than 60 years, 125 to 500 micrograms at bedtime. In children is not recommended. Second line treatments, you give melatonin oral, particularly for children. In adults, 3 to 5 milligrams daily, 1 to 2 hours before bedtime, with a maximum dosage of 10 milligrams. In children 1 month to 18 years, you give 2 to 3 milligrams at bedtime. The increase, if necessary, after 1 to 2 weeks to 4 to 6 milligrams daily, with a maximum dosage of 10 milligrams. Or you can give amitriptyline oral in adults, 25 to 50 milligrams at night for 2 weeks, and children is not recommended. Referral criteria: to refer to a clinical psychologist for those patients who do not respond to the common non-pharmacological and pharmacological interventions for cognitive behavior therapy. So refer patients with underlying physical causes to their appropriate specialists.